We usually think of, Madam is going to tell us all about dipsticks and all the tests that we could do bedside and get a diagnosis in 5 minutes of any patient that we have. A lot of times we depend on laboratory tests to give us a diagnosis, and sometimes these laboratory tests itself can make the diagnosis very confusing. And I think we really need to depend more on our clinical judgment as to make a diagnosis. So the most rapid thing that can help you to make a diagnosis is your history and examination rather than a test. So if we take onto the rapid diagnostic aids, it's going to be history, examination, and then finally it would come on to investigations. If we take system-wise, then the most common time that you require a rapid diagnostic test is basically diarrhea, respiratory system, and a fever. A meningitis, we are all aware, rapid diagnostic tests are available, the latex agglutination test is available, so I'm not going to take meningitis as a part here. But what we need to know is about pneumonia, diarrhea and fever, especially a diarrhea where we need to decide when to give an antibiotic. So when we go on to diarrhea, and we always come across acute watery diarrheas, and we are always in a dilemma, the diarrhea is not stopping. You'll end up giving valamycin on OPD basis, or you'll end up giving cefixime on OPD basis. For us, the antibiotics are the panic buttons. We tend to panic too fast, and we tend to prescribe antibiotics too fast. So let's go on to how do we approach a rapidly diagnostic aid for diarrhea. Now whenever we see diarrhea, we think of infection. Probably inflammatory bowel disease would come later. You think of lactose intolerance and you think of antibiotic associated diarrhea. Among the infections we know viral, rotavirus we've all heard about. Adenovirus is something that we should keep in mind. Enterovirus you should keep in mind. In fact, I want to stress a little bit on enterovirus now. With polio now going away, the clinical syndrome of poliomyelitis is not going away. It's being replaced by another enteroviruses. Polio itself is an enterovirus. So by eradicating polio, we are still not going to see acute flaccid paralysis going away. We still see cases of acute flaccid paralysis which are non-polio viruses. So we now have a new emerging illness of acute flaccid paralysis, that's enterovirus. In fact, I see references of enterovirus induced acute flaccid paralysis almost one a month. Bacterial causes we all know: Shigella, Salmonella, E. coli, cholera. The others that we can keep in mind is amoebic, giardiasis, cryptosporidias. Rarely community acquired fungal infections you're going to see. What is important is to identify each one correctly and then treat accordingly. So what is the checklist that we keep clinically? Rapid test, blood and stools, whether it's watery or semi-loose diarrhea, and whether the diarrhea is causing perianal rash. These 3 points on your history are extremely important. Blood and stools, you think of amoebiasis, you think of dysentery. Watery or semi-loose stools tells us whether it's a small intestinal diarrhea or whether it's a large intestinal diarrhea, and that helps us to differentiate which is the likely organism. And a diarrhea causing perianal rash pushes us more towards chemical diarrhea or towards lactose intolerance. Now let's take blood in stools. If you've got blood in stools, there are 3 possibilities. It's either inflammatory bowel disease, it's dysentery, or it's amoebiasis. How do we differentiate between all 3? Inflammatory diarrhea, inflammatory bowel disease is bloody diarrhea. There's hardly any stool, it's more of blood. It's a bloody diarrhea. Whereas dysentery and amoebiasis are basically blood mixed with the stool. So it's stools which has blood. So that's how you differentiate between the two clinically. If you get somebody saying he's just passing more of blood in stools, immediately the bell should ring. This is inflammatory bowel disease. Probably this is the time where you would actually want a colonoscopy. Now to differentiate between dysentery and amoebiasis. How often have you all prescribed a combination antibiotic for a dysentery? A combination which contains metronidazole group with an antibiotic which contains a quinolone or maybe cefixime or whatever. How often have you done that? Can I know from the audience? Everyone's nodding their head. So everybody has done that, even I have done that. The reason why I'm stressing is here because we get panicked. Oh, blood in stools, it could be amoebiasis, it could be dysentery, let's treat both. Most important point is look for tenesmus. If the patient says that the child gets pain before defecation and the pain is relieved after defecation, it's amoebiasis. So tenesmus is the most important sign. The other thing is presence of mucus. If the patient says there's a lot of mucus in the stool, it's again amoebiasis. Fever may or may not be prominent in either of them. Pus cells may not be really effective to tell you whether it's bacterial or amoebiasis, but yes, in bacterial you do get more than 10 pus cells per high power field. And the other thing is amoebiasis affects the large intestine. So it's going to be semi-loose stools. It's going to be a little more smaller quantity of stool. Whereas dysentery tends to affect your small intestine and probably a part of the ascending colon. So you're going to have more of watery, not watery, but a loose stool. So that's another thing that can help you to differentiate between the two. Now when we talk about watery diarrhea, we need to know whether it's semi-loose or watery because it tells you where the infection is. Watery is small intestine, large quantity, can lead to dehydration. Large intestine, semi-loose stools doesn't lead to dehydration. So it tells you where the infection is, and then we come to the organisms in each part of the intestine. Infections in small intestine, rotavirus, enterovirus, adenovirus, Norwalk virus, all these, viral. Giardiasis, cryptosporidiasis. Among the bacterial, E. coli, Salmonella, cholera. So these are the ones that you're going to keep in mind if you see a watery diarrhea. Now out of these, which would we be treating with antibiotics is what we have to decide. E. coli diarrhea is the commonest cause of diarrhea, especially in toddlers. Normal drinking water should not contain E. coli. If it contains E. coli, it's a sewage contamination. And we know there are 4 types of E. coli, the enteroinvasive, hemorrhagic, pathogenic, toxicogenic. We also know that one of the cause of HUS, hemolytic uremic syndrome, is E. coli. And we should not be treating that particular serotype of E. coli, that is a O157, with an antibiotic, because if you treat it with antibiotic, you predispose that child to HUS. So you need to be very careful about using antibiotic with E. coli diarrhea. The only time you require antibiotic is when it's causing dysentery, that is the enteroinvasive or the hemorrhagic variety. So that's the time you're going to use an antibiotic. The pathogenic and the toxicogenic don't require antibiotics. So bacterial diarrhea caused by E. coli, if it's causing dysentery, you use an antibiotic. If it doesn't cause a dysentery, you don't use an antibiotic. Now, among the viral, you just give symptomatic treatment. Giardiasis you need to treat, Cryptosporidia you need to treat, E. coli only if it's causing dysentery. Again, Salmonella. Salmonella causes acute watery diarrhea which is self-limited. In fact, it has been found that if you treat Salmonella diarrhea with antibiotics, you prolong the carrier stage. And these are the patients who actually become carriers for other people. If you remember the typhoid, the carrier, Mary the cook, and she was a cook in a restaurant and she used to carry this Salmonella in her gallbladder. And she transmitted typhoid bacillus to hundreds of people over a period of 1 year till she was traced to be the contact. And she had a diarrhea which was treated with antibiotics and she became a chronic carrier. So don't treat Salmonella with antibiotics. And cholera you need to treat. So among these 3 which you need to treat with antibiotics, how do you differentiate? What's the rapid test here? Cryptosporidia, persistent watery diarrhea, immunocompromised children. You will tell me you see cryptosporidia even in normal children, but it's self-limiting. You don't need to treat that. Cholera, child gets dehydrated with passage of 1 stool. Very rarely you're going to pick up hanging drop positive. And giardiasis, you think of malnourished chronic diarrhea. So these are the ways that you're going to treat for these conditions. So acute watery diarrhea, except for cholera, none of it requires antibiotic. The rapid antigen tests are available for stool. You could do a rapid rotavirus antigen test, you could do an adenovirus antigen test, a cryptosporidia antigen test is available, a giardia antigen test is also available, so you don't need to do a duodenal aspirate any longer to get a giardia antigen. Most of the labs are providing these kind of antigen tests. So when you send a stool routine microscopy, you also ask them to do the antigen test. Now, if you do a particular antigen test, it costs you money. So for each antigen, it's going to cost you money. So if you're going to get rotavirus, 900 rupees, adenovirus, another amount, what do you achieve by getting these results? Your treatment doesn't change for rotavirus or an adenovirus. What changes is basically for cryptosporidia and giardiasis. So be very reasonable when you're asking these tests, which ones you want to do. Now this is about the Dipsticks tests. These are rapid tests that are available, and they are done by dipsticks. These are the various kits that are available. You can see the sensitivity, specificity is pretty good. It's not that bad. So these tests are available. You could use it bedside. You could keep the test in your clinic and keep it bedside and use them. Let's go on to respiratory. Now respiratory, yesterday we talked about URTIs and how to differentiate between viral and bacterial and which antibiotic to use in an upper respiratory tract infection. This time we'll talk about lower respiratory. This is a 4-month-old boy who's come with cough and mild cold since 7 days, and there's increased rate of breathing since 3 days. There's no fever. So on the history, can you tell me what kind of infection is this? I don't like to hear a diagnosis of LRTI. It's a very non-specific diagnosis. LRTI means a standard prescription of nebulization, amoxiclavulinic acid, oseltamivir, and IV fluids. That's the standard prescription for any LRTI. Let's bifurcate this. What is this infection? Bronchiolitis. Why do we say this is bronchiolitis and not a pneumonia? This child is breathless. So there's no fever. The symptom is just cough and cold. No fever. So that goes against your pneumonia. On examination, you find he's tachypneic. He's got bilateral hyperresonant note over the lung fields, and cardiac dullness is obliterated. So you make a diagnosis that this is bronchiolitis. Now tell me one thing. How many of you all ask for X-rays with any lower respiratory tract infections? All of us do an X-ray. How does it change your management? I have practically stopped asking for X-rays when my residents, and I have to train my residents, don't do an X-ray unless you tell me it's a complicated pneumonia. How does the X-ray change your management? If you made a clinical diagnosis of bronchiolitis, if you made a clinical diagnosis of viral pneumonia, if you made a clinical diagnosis of croup, why do you need an X-ray? Even if you have made a diagnosis of pneumonia, why do you need an X-ray? Does it change your management? It doesn't change your management. So in what way were you wiser by asking for an X-ray test? So be a little dogmatic in asking investigations which are not necessary. Just because there's a lower respiratory tract infection does not mean you need an X-ray. Bronchiolitis, we all know that the treatment is just going to be oxygen because there is inflammation of the bronchioles, there's air trapping, and it's a viral infection. Because there's hypoxia, you need to give oxygen. Because this child is going to breathe fast, there's increased loss of water from the airways, you need to give hydration. So that's the treatment. There's no role of amoxiclav, there's no role of oseltamivir. What about nebulization? Beta agonist receptors act on the beta receptors, and both these receptors are present only in the bronchi. They don't work at the bronchiole. So there's no role of nebulization, but we still feel better at giving nebulization. We still feel that the wheeze gets better with nebulization. Yes, the wheeze does get better because you don't get isolated bronchioles. You're not going to have a virus which says, oh, I'm going to attack only the bronchioles. The virus is also going to affect the bronchi. So you can't have a virus which will be isolated to that particular area of the lung. What we say bronchiolitis means the major problem is in the bronchioles, but it could be affecting the entire pathway. So probably nebulization is working at the bronchi, and that's why the wheezing is getting better. So no role of antibiotics here. So you had a rapid test just on a clinical judgment. Virus versus bacterial infections, it's mostly clinical. Sometimes you want to do X-rays, and we have this chart which was published in Indian Pediatrics some time back about how to approach an LRTI, which said you differentiate within a wheeze. If there's a wheeze and that responds to bronchodilators, no need to give antibiotics. But if you have a wheeze that does not respond to bronchodilators, rule out between viral and bacterial and start antibiotics accordingly. Now, how do you distinguish between this viral and bacterial? You have these rapid tests that are available on a throat swab, which you could do PCRs. You have automated kits that are available which test for 11 different types of viruses. So you send a PCR throat swab, ask them to do influenza A, B, ask them to do parainfluenza A, B, C, ask them to do adenovirus, ask them to do RSV, and you'll have a result coming. You could do rhinoviruses, you could do metapneumoviruses. So you could have the result coming to you, but you're not wiser beyond that. What will it? It will also pick up a commensal. So rhinovirus would still be a commensal, so you won't be wiser. What you need to know is whether it's influenza, it's not influenza. And there's no need to know whether it's H1N1, you just want to know whether it's influenza A, B or not. So you have a rapid test that's available, it's an antigen test. You just put a throat swab, put the dipstick into it, put the reagents and see whether it's influenza AB. If it's AB, you just need to start immediately oseltamivir. So you can do this particular test that is available. You have various other, for bacterial pneumonias, you have these kits available for pneumococcal Legionella. But again, these kits don't pick up commensal versus infection. So even if you get it positive, you won't be able to differentiate whether it's commensal or it's really the organism causing an infection. Now for antibiotics for bacterial pneumonia, we know Streptococcus, Hib and Staph aureus. Treatment of choice is basically amoxicillin, amoxiclav. Why is it amoxiclav? Could anybody tell me? Why would we use amoxicillin clavulanic acid? Because the companies are telling us to use that? Isn't amoxicillin cheaper to use? Why do we use clavulanic acid? So which one of these is going to cause beta-lactamase production? Streptococcus pneumonia, Hib, Staph aureus. The resistance in Streptococcus pneumonia is basically penicillin binding proteins. It's not beta-lactamase. Staphylococcus aureus, the MRSA is basically the staphylococcal SCC gene. So it's not again beta-lactamase. It's the Hib that produces beta-lactamase. But Hib infection is common in the first 2 years of life. Beyond 2 years, you don't think of Hib. Beyond 2 years, you're going to think of strep pneumonia, staph. So if we are not going to use, so probably you would be using amoxiclav in children less than 2 years. More than 2 years, you could get away with simple amoxicillin. Only in cases of aspiration pneumonia, where you are suspecting anaerobes, you may use amoxicillin clavulanic acid, which has a work on anaerobes and some gram-negative infections. So when do you use macrolides? Again, we tend to use a lot of azithromycin thinking that it's a mycoplasma. Think of mycoplasma for a walking pneumonia. A child comes to you with fever, the fever disappears, cough persists, walking pneumonia. That's the time you think of macrolides, and especially in a school-going child. Now viral versus bacterial, a lot of us do x-rays, so there have been scoring systems that have been developed to differentiate between viral and bacterial. And this total of these various scores where you look at the infiltrate in the lung, whether it's lobar, segmental, it's patchy, whether it's single lobe, multiple lobe, whether there's fluid, whether there's abscess, pneumatococcus, atelectasis, and clinical features. And a score of 0 or less indicates a viral infection, whereas a score of 1 or greater indicates a bacterial cause. So let's do this exercise. You have this X-ray in a 5-month-old. Based on this X-ray, what do you think? Don't look at the scoring. Based on this X-ray, would you start an antibiotic or you wouldn't start? Looks like a viral pneumonia. You've got a perihilar right-sided. Okay, let's look at this. It's poorly defined. It's interstitial and it's peribronchial. Okay, it's a poorly defined shadow. There are multiple sides. You see a right perihilar, you see a left upper zone, you see slightly on the right upper zone. So it's multiple sides, perihilar, poorly defined. There's no fluid, there's no abscess, there's no atelectasis. Clinical features, I've not told you, but even if you take this scoring, this comes to -2. Age is less than 7 months. So again, that score is not there. So this is a viral pneumonia. You don't need to give an antibiotic. Oseltamivir, I told you, do a rapid test and find out whether it's influenza. So this child is either having a bronchiolitis or a viral pneumonia. Let's take this case. What do you think this is? So if we look at this, this is well defined, but it's patchy. Less well defined, patchy. It's multiple sides, but well defined. You have left lower zone, you have a right perihilar, you've got a left mid zone. You do have something like an abscess or a pneumatococcus or a bullae. So you got +3 already. This child is 2 years. So you got a clinical scoring for age also. So you got +4 scoring. So this is bacterial pneumonia or a bacterial infection, and you need to treat this. This would be the kind of an X-ray where I would want an X-ray. And when do I decide this is going to be a complication? When I have a child who's got a pneumonia not getting better on antibiotics. Okay, this is, or the child is getting worse on antibiotics, so that's the time I want an X-ray in this patient. So here the diagnosis is staphylococcal pneumonia with pneumatococcus. So LRTI is a very broad term for a lot of infections. Not all LRTIs are bacterial, and you need an objective way of assessing viral versus bacterial. Croup, bronchiolitis, pneumonia, pleural effusion, and treatment accordingly. Now let's talk about fevers. I was asking yesterday which is the common infections that you see in this part of the country, and they told me we see a lot of scrub typhus, we see a lot of dengue, malaria. So I said, okay, we can have this kind of a talk. Usually when we think of fever, we think seasonal. So in Mumbai, when we see fever in the monsoons, then these are the 4 things that we keep in mind: leptospira, malaria, dengue, typhoid. When we see fever in this season, it's a lot of times actually PO, where we don't know the diagnosis. This is an algorithm that I use in my clinical practice. It's not a validated algorithm, but I find it very useful. Whenever I see fever, I divide it between thrombocytopenia and no thrombocytopenia. If I see thrombocytopenia, I look at the hemoglobin. If the hemoglobin is high, it tells me it's dengue. If the hemoglobin is low, it tells me it's malaria. I also do a creat, but this is specifically in the monsoon time. And if I have a high creat, it tells me it's leptospira. There's no thrombocytopenia, there's hepatomegaly, coated tongue, I think of typhoid. So this is a clinical judgment. Based on this, you're going to start your treatment. By the time you get the results of your test, you've already given this child antibiotic. Now leptospira, why do I say high creat is because leptospira, you have 2 phases. You have the anicteric phase and the icteric phase. It's very different, and both the immune phase and the septicemic phase. Now, it's difficult to differentiate clinically between the immune phase and the septicemic phase. What is important in both the phases, the kidneys are involved. And the most common way of involvement is non-oliguric renal failure. So these patients are not going to come with oliguria. It's only when you check the creat you find it's high. So it's a non-oliguric renal failure. So in the monsoons, the test that we do for any patient who comes with fever is test for malaria, test for dengue, do a creat and a CBC. We know the rapid tests that are available for malaria. You have a peripheral smear, you have the optimal. I don't need to go into details about this kind of test. For the dengue, we've got the NS1 antigen, which should be sent in the first 5 days of fever. Beyond 5 days, the possibility of getting a positive NS1 is going to be low. You have a dengue, IgM, IgG. Another thing I want to stress upon of dengue, IgM, IgG is basically it's important to know that you could have a dengue IgG positive and still be harboring dengue. You need to look at the titers of the dengue IgG. And sometimes you could have a dengue IgM remaining positive for almost 3 months after the infection with dengue was there. So if you have a positive IgM, it doesn't tell you current infection. You have to look at the clinical scenario and judge whether this IgM positive is because of the current dengue infection. Test for typhoid, we have the blood culture, the typhoid and the Vidal, and we know all about it. Vidal can be sent only after the first week of illness because the chances of getting it positive in the first week are much less. Let's take this child, fever with thrombocytopenia. This is a 2-year-old girl. She presented with fever for 3 days. She's not toxic. She's vomiting for a day. You find there's hepatomegaly. You do liver enzymes, they are elevated. You have thrombocytopenia. And you do a CBC which shows leukocytosis and normal creatinine. Can anyone tell me what's the differential diagnosis you'll consider? I don't want a diagnosis, a differential diagnosis. So you think it's an acute viral hepatitis. Now when you think about infective hepatitis, remember it starts with fever and vomiting. The child is so anorexic when the fever and the vomiting is there, and when the jaundice comes, the fever is disappeared. Okay, so that's how you think of acute viral hepatitis. You don't usually get hepatitis and fever together. So any other differentials apart from acute viral hepatitis? So we think of dengue. As I said, fever with thrombocytopenia. So we've got dengue, we've got malaria, we've got leptospira. Can this just be sepsis? This child has leukocytosis. There is a count that is 27,000. Thrombocytopenia, non-toxic. So that goes little against the sepsis. So if we take a differential diagnosis, can this be a malignancy or an autoimmune? A malignancy can come with thrombocytopenia, acute onset fever. Too early to say that. Probably if this fever had persisted little longer, we would say this is malignancy or this is autoimmune. So here the differential diagnosis that we would consider is septicemia, malaria, dengue, leptospira, autoimmune malignancy. And we have ruled out septicemia, saying that this child is non-toxic. You should get a blood culture positive if you've got septicemia. Autoimmune, this child should have had some rash, elevated ESR, some sort of lymph nodes to say it's autoimmune. Malignancy, again, there should have been some sort of hepatosplenomegaly. This child does have a hepatomegaly, but there should have been some blast on peripheral smear, leukocytosis, elevated ESR. So what remains is dengue, leptospira, malaria. By the time you do an NS1, 700 rupees, IgM, IgG, another cost of money. At the end of all the investigations that you send, you tell the parents, okay, just give him water, that's the treatment. Okay, so then the parent will wonder, why did you send so many tests in the first place? So let's see, this child's hemoglobin is high, creat is normal. So creat normal, almost you rule out leptospirosis. Hemoglobin high, it's not possible to be malaria. So what remains is dengue. Dengue IgM is positive, the optimal is negative. So whenever, this is just an idea that I gave you of an approach to a child with fever and thrombocytopenia. This algorithm, I find it very useful. You could try it in your clinical practice and see whether it fits into your clinical practice. Yeah, now I'll tell you about dengue. I'm going to discuss dengue in PUs. The counts in dengues can be high because dengue is a leaky phase, right? You have a lot of vasculitis, there's a lot of leaking that is occurring, and you could have the gut bacteria leaking into the system. So you could have leukocytosis because of a secondary infection. Second, it's a stress that causes, dengue causes a lot of leaks again. So there's a lot of stress. So it's not unusual to get leukocytosis. The most, what we say in the books, leukopenia is more common in dengue, but it's not unusual to get leukocytosis. So if you have leukocytosis in a dengue, think of a secondary gram-negative sepsis along with it. So now I'm going to conclude this, that rapid diagnosis is usually clinical. And you ask a rapid diagnostic test based on your clinical judgment. You don't send tests of each and everything. And most of the times you'll get a diagnosis based on your history and examination, and rarely you would need to do all these rapid tests to make a diagnosis. Thank you very much.